As you know, today's topic is electrocardiography. What is electrocardiography? Electrocardiography is a graphical representation of heart. Graphical representation of which has been recorded by metal electrode which has been attached to the periphery and to the center or over chest, and they are amplified and they are recorded by the ECG machine, which is nothing but galvanometer. And ECG leads are configured in such a way that they record instant or instantaneous difference between the electrodes. So, for example, lead 1 and lead 2, between lead 1 and lead 2, lead 2 and lead 3, or lead 1 and 3. As I will proceed, you will come to know that. ECG is very highly versatile test, instantly available, and it has no substitute. See, even in today's generation, even you do 2D echocardiography or angiography or whatever, but till today there is no substitute. ECG has no substitute, and over a period of 100 years it remains the same. There is no new advantage. The waves which were been detected earlier, like P, Q, R, S, T and U, are the same today which were there 50 to 100 years back. See, before going into detail about ECG, one should know, or you already know, that when you build a building, you don't build building from the ground, you have to go deep. So, foundation is very important. So, if you want to build a very tall building, you have to go more deeper. So, what is important? So, important is cardiac anatomy, cardiac electrophysiology is more important. So, we will start now first with cardiac anatomy and electrophysiology to make your the basics very strong. If you make this basic strong or your foundation strong, as you see, when buildings are built, they have to go deeper and deeper. More the taller building, they have to go more in the depth. So, what will happen? Why so? Because once you go deeper or you go in depth, then you will stand still in cases of emergency. You won't shake, because it is a routine as well as emergency investigation. So, let's, without wasting time, we'll start with the basics. Now we'll start with cardiac anatomy, electrophysiology, and subsequently like action potential and all that. Let's start with this thing. First, to understand it, we'll do with the square diagram of the heart. As you know, this will become very easy for you. See, it is very simple diagram. This is right side, this is left side. Right side contains deoxygenated blood. So, from where deoxygenated blood comes? From the lower part of the body. It comes to the right side of the heart, that is right atrium, by means of inferior vena cava, IVC, and upper part of the body, the blood will come from SVC, superior vena cava. So, once bloods come to the right atrium, it will go to the right ventricle, RV. So, it will go to the RV. From RV, this blood is deoxygenated blood, because the oxygen has been already used by the body. So, we need to oxygenate this blood. So, this blood from the right ventricle it will go into pulmonary artery. From pulmonary artery it will go to the lungs, to lungs. Via pulmonary artery, deoxygenated blood will go to the lungs for oxygenation. Once oxygenation will when the gas exchange occurs at alveolar level, the oxygenated blood will come to the left side of the heart, that is left atrium, by means of 4 pulmonary veins. Why pulmonary veins and why this is artery? Artery because it is going away from the heart, that is why though this is pulmonary artery, it carries the deoxygenated blood. Now blood has come to the left atrium via 4 pulmonary veins. Now this is left atrium, and from left atrium it goes to the left ventricle. From left ventricle now this will go to the systemic circulation. So this is aorta. So blood coming from the upper and lower part by means of inferior vena cava from the lower part, superior vena cava from the upper part of the body, the blood will come to the right atrium. From the right atrium it will come to the right ventricle. Right ventricle it will via pulmonary artery it will go to the lungs, from where this blood from after getting oxygenated at alveoli it will come directly to the left side of the heart, that this is the left atrium. So from left atrium it will go to the left ventricle, from there it will go to the body via means of aorta. So aorta, ascending aorta, arch of the aorta, descending thoracic and descending abdominal aorta, and whole oxygenated blood is circulated in the body. So the there are walls in between. This is tricuspid wall, this is pulmonary wall, this is mitral wall, and this is aortic wall. There are 4 walls. Tricuspid wall, see this you will need, this understanding you will need when you need to understand the ECG. Otherwise just learning, I can teach you the waves, but that knowledge won't last longer and your basic fundamentals will not get clear. Unless you know this, it is not going to be useful for you. So, and many of you know already this, because you are in the already practicing or in medical profession, but the students, the paramedics, they must learn, or you may skip this, or you may skip this video also. So now here I want to tell you, when blood comes in the RA from the venous circulation, the wall is closed, tricuspid wall is closed, and when the blood is accumulated in the right atrium, then this wall gets open and this blood gets collected into the right ventricle. That time the pulmonary wall is closed, this pulmonary wall is closed. Now what happens, when the blood comes in the pulmonary walls or right ventricle, then what happens, but from blood from the right atrium to right ventricle gets filled in 3 stages. 3 stages are: first, rapid filling phase, second is a passive phase, and third is with contraction of right atrium. So once the wall open, immediately blood falls into the right ventricle. Second, there is a middle phase, and in last phase there is a systole. Systole means contraction of the right atrium. Right atrium will contract, the blood will come into the right ventricle. When the blood comes to the right ventricle, this wall gets closed. This wall is also not open. The both are closed because the pressure inside the right ventricle is lower than the pressure in the pulmonary artery. So here what happens, then now the next thing what will happen, then there will be a isovolumic contraction. Same thing will happen simultaneously when blood is coming from RA to RV. Same time the blood will come from pulmonary vein to from the left atrium to the left ventricle. So this is simultaneously, not one after the another. While coming, the blood is coming from here to here, same time it will come from left atrium to left ventricle. When blood has come in three phases, like first rapid filling phase, second is passive phase, middle phase, and third is with the contraction of the both ventricles. So RA and LA both contracts. So we call it as atrial systole. When they gets contracted, almost 30% of the ventricles they get filled up. So now once we go further, when we see atrial fibrillation, so what happens actually atrial fibrillation? Atrial fibrillation, the atrial kick or atrial systole is absent. So that's why whenever there is atrial fibrillation, the ventricle person doesn't die. The ventricles are filled less, 30% less. So whatever the volume is collected, suppose 100 ml, it will be a 70 ml because 30% are less, because this last rapid filling phase with the contraction of the respective atria, left atrium and right atrium, both are contracting. Last filling phase, that time the tricuspid wall open, mitral wall is open, blood has come from here to here, here to here. Now after this thing, they are closed, these are not open, so this whole chambers are closed. Now what happens, the pressure inside the aorta is more than left ventricle, pressure inside the pulmonary artery is more than the right ventricle, that is why these are closed. So what will happen, there will be a isovolumic contraction I was telling you. So when both the walls are closed, the ventricle goes in contraction, systole. If you have some fluid in a balloon and if you press that balloon, the pressure inside balloon will increase. So the pressure will increase here. As pressure increases, both the walls will get open and blood from the pulmonary artery, blood from the right ventricle will go into the pulmonary artery and subsequently to the lungs, and blood from the left ventricle will go into the aorta for the systemic circulation. As blood is ejected at the end of systole, what we call it, whenever we talk about systole, that means it is always pertaining to the ventricles, and when I talk about the atrial systoles, I will specifically mention atrial systole, right atrial systole, left atrial systole. Otherwise, when the only term of systole is used, systole, so it is pertaining to the ventricle. Now blood has come from pulmonary right ventricle to the pulmonary artery and to the lungs, and left ventricle to the aorta to the systemic circulation. At the end of the systole, these walls are closed. While these bloods is ejecting into the pulmonary and systemic circulation, when these walls are closed, these walls are open, now blood is ejected here. That time what happens, they are continuously receiving the blood here, because there is no time. One cardiac cycle only takes 0.8 seconds approximately if the heart rate is 72. So the while this is getting ejected, this has to be filled, na? So continuously it is receiving blood from inferior vena cava and superior vena cava, and left atrium will receive blood from pulmonary artery. So they are getting filled up same time. Okay. Now remember, it was a isovolumic contraction, wall has opened, blood has rushed to the pulmonary circulation, here blood has rushed to the systemic circulation. Now at the end of the systole, these both walls are closed. When these walls are closed, but these are not opened. Now the situation is what? Systole has occurred, blood is been ejected, pulmonary wall is closed, aortic wall is closed, tricuspid is not open and mitral is not open because they have to eject the blood in the respective circulation. So now, but the pressure inside is very high. So at the same time, now they need to relax. Why? If they relax, then the pressure in both the chamber will reduce, and when the pressure in both the chamber will reduce, these walls will open. So the pressure has to be below the right RV pressure should be equal or below the right atrial pressure, or this pressure and this pressure should be equal to open this wall. So now that phase is known as isovolumetric relaxation. Now you say why it is very important isovolumic, why we need only ECG to learn, and why you are talking about this, why? Because this is very important, because many condition, if you face a condition like, or if you read, or I will tell you for the condition like restrictive cardiomyopathy, where the relaxation is very low, or severe hypertrophy, there also the isovolumetric relaxation time, they call isovolumetric relaxation time, they call IVRT, is reduced. When isovolumetric relaxation time is reduced, then the filling of both the ventricles will be less. So that's why it is very important to know isovolumetric relaxation. When there is a isovolumetric relaxation, the blood again will flow from RA to RV, from LA to LV, then it will get filled up in 3 phases, and both the wall will close, then it will go again into isovolumic contraction, the pressure inside this will be higher than this, and the blood will go to the systemic circulation, and this whole thing is continuously will get repeated and repeated. That's all. This is the cardiac cycle in short. Okay.